Hi, this is Dr. Gary Siskin, and today I'm going to be speaking to you about embolization of renal angiomyolipomas. Angiomyolipomas, otherwise known as AMLs, are benign mesenchymal tumors consisting of blood vessels, smooth muscle-like cells, and fatty tissue. They're the most common benign solid renal tumors and account for approximately 3% of all renal masses. They're seen in males and females, with a slightly greater incidence in females. And this reflects an overexpression of estrogen receptors, progesterone receptors, and aromatase within an AML. AMLs occur either sporadically or in association with tuberous sclerosis. The sporadic AMLs are much more common, making up 80 to 90% of all AMLs. These tend to be unilateral, solitary, slow-growing, and moderate in size. Most of the remaining AMLs are seen in association with tuberous sclerosis complex. This is an autosomal dominant genetic disorder that includes multiple hamartomatous lesions throughout the body, and these include subependymal nodules, subependymal giant cell astrocytomas in the brain, AMLs in the kidney, lymphangioliomyomatosis in the lungs, and rhabdomyomas in the heart. Hamartomas can also be seen on the skin, retina, and nails. AMLs are found in 50 to 80% of patients with tuberous sclerosis complex. These tend to grow faster than sporadic AMLs, and they tend to be larger, bilateral, multiple, and symptomatic. Imaging is commonly done in these patients, and the goals of imaging include being able to identify the characteristics leading to a definitive diagnosis of an AML. We always want to measure the size of the AML, and we want to describe the extent and appearance of the tumor vascularity supplying the AML. On ultrasound, an AML is almost always hyperechoic relative to renal parenchyma, and this is due to a combination of fat content and blood vessels within the tumor. Posterior shadowing can be seen and is most likely due to the multiple tissue interfaces between fatty and non-fatty components of the mass. On CT, AMLs can be diagnosed with confidence when you see a non-calcified fat-containing mass, and other features include enlarged or bridging vessels and aneurysms. While almost any masses can be included in the differential, we most likely are concerned about differentiating between a renal cell cancer and an angiomyolipoma, and when we see calcifications, it's more likely a renal cell carcinoma than an AML. On MRI, we're looking for macroscopic fat on T1 weighted images and can use fat suppression for confirmation. It's important to remember that 5% of AMLs lack macroscopic fat and are considered fat poor. And in these cases, chemical shift sequences may help detect intravoxel fat. So fat-poor AMLs are one of two variants to consider. These lesions don't reveal any fat on non-enhanced CT. They can be hyperattenuating or isoattenuating compared to normal kidney. And homogeneous enhancement is usually seen when contrast is administered. On MRI, they can be hypointense on T2 weighted images, and they do homogeneously enhance. Biopsy is usually required when these lesions are seen in order to differentiate them from renal cell cancer. Pathologically, they contain no more than 25% fat cells per high-powered field. The other variant to consider are epithelioid AMLs. These are rare tumors which are locally aggressive, and they can be associated with metastatic disease. 1/3 of them may demonstrate local extension or distant mets at presentation. They're composed of atypical epithelioid cells, they're highly cellular, and they're fat poor. And again, they can look like renal cell cancer on imaging and under the microscope. Because of that, they can require a biopsy for diagnosis and often require surgical resection. So why do we worry about AMLs? Well, for starters, they grow, and with growth can come symptoms. And symptoms include abdominal pain, a palpable mass, macroscopic hematuria, and hypertension. Tumor growth can also increase the risk of rupture and bleeding, and these symptoms can include the sudden onset of flank pain and hypovolemic shock. The blood vessels within an angiomyolipoma are rigid with no internal elastic lamina. In addition, the smooth muscle can be replaced by fibrous tissue, and these changes can lead to aneurysm formation. It's these distinct interlobar and interlobular aneurysms which can be diagnostic of an AML and can lead to rupture. So when we talk about managing a patient with an AML, the goal of management is essentially to avoid rupture. So here's the bad news. The bad news is that rupture can occur and can result in significant morbidity. And remember that the incidence of rupture is higher in patients with TSC-associated AMLs than with sporadic AMLs. The good news is that the incidence of rupture is rare and is not usually associated with mortality. The incidence has been estimated at 0.4 to 2.5% at 4 years, which equates to an annual risk anywhere from 1 to 164 to 1 in 1,000. Most patients, meaning greater than 80% of patients who experience rupture, present with pain and or hematuria, but are hemodynamically stable. Only less than 20% are hemodynamically unstable. And this may be because when an AML ruptures, it's a small vessel hemorrhage within a relatively small perirenal space, which contains the bleed. Less than 10% extend into the retroperitoneum. The bottom line is that while rare, rupture of an AML does carry significant risk and is preventable, but this can only occur if we identify the patients at risk for rupture. And in order to do that, we have to look at its size, vascularity, and symptoms. Size became a more apparent issue with the publication of the paper by Osterling in 1986. This paper suggested that AMLs greater than 4 centimeters are at an increased risk of rupture, and this threshold has been widely adopted in subsequent practice. In this paper, 82% of tumors that were greater than or equal to 4 centimeters were symptomatic, while only 23% of those less than 4 centimeters were symptomatic. They reported a higher incidence of problems associated with rupture as well. Greater than 50% of tumors that were greater than or equal to 4 centimeters experienced acute hemorrhage, with shock seen in 1/3 of these patients. So for an angiomyolipoma, risk is defined by size. As the size increases, the risk increases. And we look at the size based on the risk of treatment. And I think we can make the case that the risk of embolization decreases with AML size. And that's because the vessels are larger and there's a more visible target. So when we're below the threshold of 4 centimeters, we tend not to treat because the risk of treatment may be greater than the risk of the pathology. But above 4 centimeters, we typically treat because at that point, the risk of the AML outweighs the risk of treatment. Vascularity is another characteristic of AMLs that we look at, because highly vascular AMLs are more likely to rupture than minimally vascular AMLs. And in fact, minimally vascular AMLs may not require embolization at all. Intratumoral pseudoaneurysms greater than 5 millimeters are indicators of increased vascularity and are considered a risk factor for rupture. And finally, we look at symptoms. A significant change in symptoms, most notably flank pain, can potentially indicate pending rupture. So these patients should be considered for prophylactic embolization. But before we get there, we have to talk about medical treatment, because mTOR inhibitors are now used to treat AMLs, because they've been shown to reduce size and reduce growth by addressing proliferation, angioneogenesis, cell metabolism, and cell migration. The EXIST-2 studies and extension studies have shown that 6-month treatment can reduce AML volume by greater than 50% in more than half of patients. And adverse events included nasopharyngitis, stomatitis, and headache. And these results were enough to consider mTOR inhibitors as first-line treatment for AMLs that are greater than or equal to 3 centimeters in size, even when asymptomatic. But let's talk about embolization. The obvious indications for embolization include rupture with active hemorrhage and symptoms which are indicating pending rupture. Embolization can also be used preoperatively, and this should be considered prior to nephrectomy for lesions greater than 7 centimeters, since it can reduce intraoperative blood loss, length of stay, and residual tumor volume. The most common indications that you're probably familiar with include prophylactic embolization to prevent rupture, and this can be done in patients with AMLs greater than 4 centimeters in largest diameter and patients with intralesional pseudoaneurysm formation that are greater than 5 millimeters. There are some other indications as well, including patients who may require renal replacement therapy if a rupture should occur, patients who live where access to emergency treatment is limited, patients in whom education and early clinical presentation are challenging, patients with poor physiological reserve where rupture may be poorly tolerated, and patients with evidence of a prior missed AML rupture. Before moving to selective catheterization and embolization, it's important to make sure that we've seen the aorta well, and this could be done with aortography or on pre-procedure CTA. And the goal there is to make sure there are no accessory renal arteries, because this can explain why tumor vascularity may not be evident on angiography of the main renal artery. In other words, if you miss an accessory renal artery, you won't know for sure that you have evaluated the kidney in its entirety, and that may cause you to miss the vascularity of the AML. It's also important to remember that large tumors, those greater than 10 centimeters, usually can recruit blood flow from surrounding arteries, and this can include adrenal, ureteral, gonadal, phrenic, and lumbar arteries. These alternative sources of supply need to be addressed in order to avoid recurrence after embolization. This type of recruitment is not usually seen in lesions less than 6.5 centimeters. And I'd like to show you 2 examples of that. This is a patient with a large right-sided AML. Initially, when we went to embolize this patient, we appreciated that a capsular vessel was helping to supply the tumor, and we were able to embolize that in addition to some of the main renal artery branches. But later on, we appreciated that this patient also was receiving supply from a lumbar artery. And you can see the vessel arising from the mid portion of the lumbar artery and running north. And on selective angiography of that branch of the lumbar artery, you can appreciate the fact that it was supplying the more inferior aspect of the angiomyolipoma. Here's another case where a prominent branch, probably arising from the median sacral artery, was providing supply to the inferior aspect of a different patient's angiomyolipoma. Ultimately, the goal with an AML embolization procedure is to achieve a distal catheter position within the main feeding arteries to the tumor in order to reduce the likelihood of non-target embolization and help preserve normal renal parenchyma. The angiographic findings, which include highly tortuous neovascularity as well as pseudoaneurysms, usually are evident, and they can confirm catheter placement. And this is what a typical angiomyolipoma may look like, with, as mentioned, the small pseudoaneurysms and the marked tortuosity of the neovascularity. When it comes to embolic agent selection, there really is no consensus regarding which one to use. Success has been reported with absolute ethanol, gel foam, PVA, embolic microspheres, and onyx. At our center, we use the PEN protocol for embolizing these angiomyolipomas. This uses absolute ethanol and lipiodol at a 7:3 ratio. And we do that since it's easy to administer, it diffuses through the entire tumor vasculature, it permanently occludes the arteries at the capillary level, and results in tumor infarction and necrosis. And really, most importantly, it's pretty cool to do, because as you watch this embolization, you can see the lipiodol droplets carrying the ethanol out into the distal portion of the tumor. And that's always very gratifying during a procedure. The dilution is important since overdilution can lower efficacy and increase reintervention rates, while underdilution can result in poor visualization and increase the risk of non-target embolization. Non-target embolization due to reflux is the major risk with ethanol, and balloon occlusion microcatheters can help prevent that. If using a particulate agent, an important consideration is the size of the particle or microsphere selected. And smaller particles in this case may actually be less effective than larger particles and more likely to be associated with acute pulmonary distress following therapy. This may be due to small, unrecognized AV fistulas. So the suggestion is to use particles larger than 150 microns in diameter. Following the procedure, patients can be discharged home after a 4 to 6 hour recovery period. It's probably more common for patients to be admitted for overnight observation. Post-embolization syndrome is something that can be seen in up to 80% of patients. The symptoms include mild flank pain, fever, nausea or vomiting, and leukocytosis. This typically lasts for 1 to 3 days after the procedure, and supportive outpatient treatment is standard. Fortunately, AML embolization is very safe. Complications are rare. The things we worry about include non-target embolization, because this can include infarction of normal renal tissue with the potential for loss of renal function. Other complications include respiratory compromise, renal abscess formation, rupture of the AML, hypersensitivity reactions, urinary retention, groin complications, renal artery spasm, and pleural effusions. In terms of follow-up imaging, CAT scans can be done roughly every 6 months for 2 years, and subsequent visits and imaging then depend on the etiology of the AML. We typically follow patients with TSC-associated AMLs at 12-month intervals, and we follow sporadic AMLs at 24-month intervals, assuming there are no recurrent symptoms. We want to see a reduction in size after embolization, but the size reduction often depends on the volume of fat within the AML. The muscle and vascular tissues typically regress after embolization, while the fatty tissue does not. Therefore, lesions with more muscle and vascular tissue are associated with a greater size reduction after embolization than the reduction seen in fat-rich AMLs. Approximately 40 to 70% of AML show a reduction in size, and most case series quote that reduction as 24 to 57%. Increasing size on follow-up imaging is considered a bad sign and may lead one to recommend repeat embolization. The fact is, any increase in enhancement or vascularity should also be considered suspicious and warrant either close follow-up or a repeat embolization procedure. Repeat embolizations occurred in about 40% of patients after an average of 2 to 3 years from the index procedure. Most retreatment is done due to a failure to shrink, growth, or persistent symptoms. And risk factors for repeat embolization include TSC-associated AMLs and younger patients with larger tumors and left-sided tumors. In conclusion, embolization is an effective treatment for bleeding associated with ruptured AMLs and as a prophylactic treatment to prevent rupture in this patient population.